Let me begin with just a line from Kabir. Something inside me has reached the place where the world is breathing. Something inside me has reached to the place where the world is breathing. So I hope you can, it's bright in here this morning, I hope you can see the PowerPoints okay. What I'm going to start with is just reflecting on the phrase in the title of our presentation, Learning to Breathe Underwater, because you may be wondering what we're proposing here. And this phrase was actually a phrase that we included in a paper that that Radhule and I, along with co-authors Mary Vachon, Richard Harrison, and Val Fermant, wrote on the self-care of physicians at the end of life. And it was a phrase that we included in this paper. And this was a paper for JAMA, the Journal of the American Medical Association, which is a very evidence-based paper, meaning that unless you can support everything you say with data, they're going to ask you where your sources are for this statement, and if you don't have them, can you please remove it? So you can imagine that they were challenged by the phrase, learning to breathe underwater. And this was actually how we put it. Self-care with self-awareness is like learning to breathe underwater. And so one of the JAMA editors wrote back to me and said, one last question, can you please explain the importance of the breathing underwater metaphor? I keep deleting it because people cannot breathe underwater. So to me, the metaphor would mean that self-care with self-awareness is impossible. Since you keep putting it back in, can you explain why this particular metaphor is important? What I didn't say to her is that it was mainly coming from maybe my Irish poetic background, that it made poetic sense. That wasn't going to cut it with JAMA. So I wrote back and I said, well, when we feel like we're drowning at work, overwhelmed and going under, the normal response is to hold our breath, as in maintaining clear professional boundaries, and to come up for air just as soon as we can, to have an effective self-care program in place for when we leave the workplace. Self-awareness-based self-care is counterintuitive. At first glance, it's describing the impossible, that the work itself could be a source of oxygen. But this is precisely what self-awareness-based self-care makes possible. So that's where that phrase comes from, and that's the entry point to our presentation this morning. We're talking about self-care, and we're talking about a model of self-care that is based on self-awareness, and how this not only is helpful in terms of self-care, in terms of preventing some of the occupational stress syndromes I'll talk about briefly, but also how it makes us more effective in our caregiving, more empathic, more highly present, more effective, less likely to make medical errors. So let's just begin by quickly touching on the two occupational stress syndromes that we're most familiar with, burnout and compassion fatigue. Burnout and compassion fatigue are really quite different, both in their genesis and in terms of their presentation. Burnout results from stresses that arise between the individual and their work environment. For example, we follow in that JAMA paper, we follow the progress of an oncologist, his story through the paper. His name was Dr. C, and Dr. C said, the stuff that burns me out is not the loss, it's fighting with insurance companies. So it's that kind of occupational environmental bureaucratic stress, if you like, that over time gives rise to burnout, which is highly prevalent among US doctors and nurses, 30%, according to Maslach's research. So how it actually presents is in terms of three key areas. One is that of overwhelming physical and emotional exhaustion. The second is with feelings of detachment and cynicism, kind of withdrawal, dissociation. The third is a sense of ineffectiveness and lack of personal accomplishment. So these are the three sort of key features of the burnout syndrome. And any one individual who's experiencing burnout may have more of one and less of another, but that tends to be the cluster. In contrast, compassion fatigue evolves specifically from the relationship between the caregiver and the patient. So in contrast to burnout, where it's the individual and the work environment, here the sources of stress that give rise to compassion fatigue are generated in that interpersonal interaction. It's also known as secondary traumatic stress disorder. And Charles Figley, who has written extensively about compassion fatigue in terms of secondary traumatic stress disorder, makes the point that in being empathic to our patients in suffering makes us vulnerable as caregivers. So even though the patient is experiencing the suffering, by being empathic, we are, within this hypothesis, at risk of being secondarily traumatized. And so the symptoms, if you like, of compassion fatigue are the symptoms of PTSD. It's secondary traumatic stress disorder, or vicarious traumatization is how it's also referred to. And so the symptoms may be those of increased arousal, as in irritability, difficulty in concentrating, re-experiencing, going over and over again the traumatic event, sleep problems, including nightmares, just distress when at work and kind of walking by the room where that particular traumatic event occurred, for example. And then avoidance, it may be literally that we go another way through the hospital so we don't have to walk by the place where the trauma happened. Or it may begin to manifest as dissociation, numbness, leading into perhaps social withdrawal. So these are some of the cluster of symptoms of compassion fatigue. And over time, compassion fatigue can turn into burnout. So really, I'm not going to talk a whole lot more about those two syndromes, just put those up as a backdrop. What I really want to focus on here is empathic engagement. And what I found, what we found particularly problematic in this way of viewing compassion fatigue is that it portrayed empathy in terms of liability, that empathic engagement in the relationship of another who is suffering is itself a key causal factor or a liability to developing compassion fatigue. As Figley puts it, the caregiver's empathy level with the traumatized individual plays a significant role in this transmission, almost suggesting that the more empathic we are, the more vulnerable we are to secondary traumatization. So we were, while we could kind of recognize the validity of this up to a point, it really didn't speak to our as a group that were kind of sitting talking together about how we write about this and how we think about compassion. It somehow didn't tie in with our own experience. And so we were lucky at this time to come across a paper by Richard Harrison. In fact, Richard Harrison was one of our co-authors on the JAMA paper. And this was a synopsis of his graduate work, where he interviewed a number of trauma therapists. And these were identified by their peers as thriving in their work. And so what he and his colleague Westwood did is they interviewed these trauma therapists who were seen as exemplary and thriving in their work, and then using qualitative research methodology, they analyzed the responses to identify how they did this. Trauma therapists often in work for more than 10 years, their daily practice involving working with people who are highly traumatized, and yet they were thriving in their work. And so they identified a number of protective practices. And one of these was the practice of what they called, if you can see it there, exquisite empathy. And how they defined exquisite empathy was a form of empathic presence that is highly present, sensitively attuned, well-boundaried, and heartfelt for another who is suffering. And what they added is therapists who engaged in exquisite empathy were invigorated rather than depleted by their intimate professional connections with traumatized clients. The practice of exquisite empathy, and here's the rub, the practice of exquisite empathy is facilitated by clinician self-awareness. So really what distinguishes exquisite empathy from, if you like, regular empathy is the presence of clinician self-awareness. And somehow the addition of clinician self-awareness to the equation meant that the empathic engagement, rather than being depleting or potentially an avenue for traumatization, was actually a source of potential renewal and healing for the clinician, himself. So this begs the question, what is clinician self-awareness? What are we talking about when we talk about clinician self-awareness, and how can this be developed? And over to Radhule.
So good morning. So we thought of clinician self-awareness as having 4 aspects: mindful awareness, contemplative awareness, self-knowledge, and self-empathy. And I'm sure you can find other definitions, but that is how we thought of as useful. Self-knowledge and self-empathy are embedded in a field aspect of mindful and contemplative awareness. And I was just reminded of my dear mentor, Jack Kornfield, who said that we could see mindfulness as having a field aspect, a wave aspect, can be seen as wave and as particle, as having a field aspect and a momentary aspect. So we can be mindful in the moment, moment by moment, but we also can rest in awareness. And the more we practice ongoing practice of mindfulness, the more we build up this field aspect of awareness in which we basically can rest and then come into the moment to moment. So I was just wanting to recap the aspects of mindful awareness as we use them moment to moment in our practical life. There is focusing, the deliberate cultivation of focused attention by stabilizing the mind. And, we all know that being distracted and all over the place, multitasking is one of the greatest challenges of life. My teacher, Alan Wallace, calls it the OCDD mind, the obsessive-compulsive delusional mind. And then the next aspect I would call is noticing. as we have a little bit of stability in our minds. It's the ability to notice shift of one's emotions, thoughts, sensations, while holding a friendly and curious attitude towards ourselves. So as our mind calms down, is able to have some ability for attention, we learn to notice how phenomena are passing by like clouds in the sky. And the main important aspect is to neither grasp nor push away, which is a really difficult task to learn. And then the next aspect we call expanding, and that is a quality of awareness that allows one to simultaneously attend to another, to the environment, and to one's own subjective experience. We also at times call that dual awareness. And that is, I think, probably the one that is most important for us as clinicians, to really be connected with ourselves while being challenged by what is going on in our clinical practice. The opposite would be reactive awareness, and that is unfortunately the usual mode of awareness in practice when we are not mindful. So in times of stress, awareness collapses into a constricted view of reality and more reactive modes of behavior. And I think I'm quite excited that, now I'm studying mindfulness meditation for 32 years, that in the last 10, 15 years, I see more and more attempts of how to bring in applied mindfulness, how to bring it in from the cushion into daily life when we get triggered. And I can see in the program quite a few people are trying to tackle this task, and we'll bring in a few attempts to work with that. So self-knowledge. Self-knowledge is really important to develop and includes the clinician's understanding of his/her family background, religious, cultural background, his/her emotional and psychological process, and having worked through personal issues that could lead to prejudice, stereotyping, and counter-transference reactions. And we all know therapy is really useful for acquiring that self-knowledge. No? So self-empathy, I think ever since there was this incident with Sharon Salzberg and the Dalai Lama, where she talked about how Westerners are so very much self-loathing, and he asked, self-critical, and he asked his interpreter what that word meant, because he didn't have that word in Tibetan, I guess, self-critical, self-loathing. And then the interpreters tried to explain to the Dalai Lama, and he made this, it's like how he can do this so well, when he's really surprised. And so that's when the Tibetans understood how big that is a problem for us Westerners, to be self-critical, to put ourselves down, to be competitive with our own self. And it's interesting, I was the last 2 summers in Dharamsala and had a lot of interviews with the Dalai Lama's interpreter on Buddhist and Western psychology. It's really a cultural difference. And so we Westerners, we have to be very patient with ourselves and very gentle in trying to work with our propensity to be critical with ourselves and with our own feelings of unworthiness. And to develop self-compassion, which is the willingness to have our own back, to help ourselves out. Oh, careful of time. Okay. Careful of time. Contemplative awareness is, our awareness, how we as individuals are situated in the bigger field. And that means our awareness of our spirituality and sources of meaning, which might be quite different than those of our patients, clients, and also be able to be aware of and use rituals and practices that allow us to direct our experience towards the numinous and sacred, our own access to the field of awareness. And for me, as a Buddhist, this bigger field is the one of radical interdependence or mutual co-rising of all reality and all beings. And then compassion follows from that naturally. So cultivating and practicing self-awareness, we can see as having two steps. The first one is to develop self-awareness as ongoing practice. And if we have that ongoing practice, it's like shaping our neural pathways slowly, slowly. We have much more access to mindful awareness, self-knowledge, self-empathy, and contemplative awareness. And then we can use those skills in the present moment by practicing what we call exquisite empathy and compassion, which is then being with a much higher quality with another person, with sentient beings, with beings in general, and with our world. So Michael will be talking about about exquisite empathy a little bit more. I just wanted to mention other evidence-based ways of increasing self-awareness. There's mindfulness meditation or centering prayer, reflective writing, supervision, mentoring, peer group support, educational initiatives, research initiatives, psychotherapy, and spiritual direction. I personally find in my own case and with a lot of my interns and students that mindfulness meditation and psychotherapy really kind of is a wonderful complement to each other. Lastly, we wanted to introduce a chart which I would call the chart of applied mindfulness, which is the emotional awareness worksheet, and we will introduce the emotional awareness process guide, which we have been developing over the last few years, and which is an attempt to bring mindfulness into moments when we are triggered, when we are thrown out of balance. And to, actually I talked about this with Jack Cornfield in the spring after I did a 4-week retreat, and he said, this chart in a way does a similar thing than a 4-week retreat if we don't have time to do that. Well, you know, there are lots of things about a 4-week retreat we can't do in the chart, but the insight aspect is definitely addressed.
Thank you, Radhule. And the emotional awareness worksheet, which Radhule has developed based on the work of the encouragement of the Dalai Lama to psychologist Paul Ekman and Buddhist scholar teacher Alan Wallace to really bring applied mindfulness forward in a practical way. And so as part of that initiative and a training that Radhule did with Paul Ekman and Alan Wallace, she's developed this particular chart that you just saw. And we'll be going into that in more detail in our workshop. So the other aspect of self-awareness, the first being developing it as part of our ongoing practice. The second is applying it in the moment. And what I'd like to do in the next 10 minutes or so is look at how we can do this. And actually, I'm going to be doing that a little bit through the lens of depth psychology, so bringing in a slightly different perspective that I think can be very useful. And this is really a visual synopsis and summary of a number of chapters from a book by the Jungian psychologist, depth psychologist Adolf Guggenbull Craig, called Power and the Helping Professions. A wonderful book, especially if you're interested in depth psychology. So we're going to look at the interaction between the clinician and the patient and understanding, hopefully, the importance of applying self-awareness skills in the moment and what this might actually look like. So each individual, the clinician and the patient, is represented by the egg you see here, or the egg really represents that individual's psyche, and having an upper part and a lower part corresponding with the conscious and the unconscious. And the unconscious, as you know, is the place of repressed memory, feelings, and also within the Jungian map of the unconscious, the place of the archetypes. And very, very briefly, my understanding from reading Jung of the archetypes is in seeing these as innate, inherited, latent archive of wisdom within the unconscious, and within that dimension of the unconscious that Jung refers to as the collective or the shared or the universal aspect of the unconscious. And that these constellations of wisdom can be activated or constellated, using the Jungian language, in specific circumstances. So we encounter something in our everyday life that somehow speaks to a specific archetype. And the archetype, as a reservoir of wisdom, is activated by the external circumstance, or constellated, and then begins to inform that individual through intuition, through dreams, of a possible way to sort of navigate their way through this particular life challenge or life situation. So with that little bit of backdrop, what we're looking at here is a particular archetype called the wounded healer archetype. And here we have clinician and patient, both of whom carry within their unconscious the wounded healer archetype. It's not like the clinician just holds the healer archetype and the patient the wounded archetype. The archetype is dyadic or bipolar, and every individual within this hypothesis carries the archetype. The reason we're looking at it here is that it speaks, I think, really well to the dynamics of the healing encounter. So, patient approaches clinician with a problem. I've got a pain, I'm in pain, or I've got a broken hip, whatever the problem is, or I've got a chest infection, I need your help. So, according to Guggenbull Craig, there are two possibilities. The first of these is what he calls the power relationship. And so within the power relationship, the clinician identifies uniquely with, or solely with, the healing pole of the archetype, and vice versa. The patient identifies uniquely with the wounded pole of the archetype. And in either case, the other aspect, in the clinician's case, the wounded aspect, the patient, the healer aspect, is repressed, and that's represented by the thick black line. It goes underground, and it's lost. So this is really what gets played out in a scenario with a non-aware or a non-self-aware clinician. And there are potential positive consequences. Clinicians don't need to be that self-aware, perhaps, to do some really good and successful therapeutic work. With skill and what it takes, the orthopedic surgeon puts in the pin and fixes the fractured hip, and the outcome is successful, a cure. So that's a potentially positive consequence of the power relationship. But what if the intervention is unsuccessful? And when we're talking about contemplative care at the end of life, the context of end of life is a context where we're constantly bumping into the limits of what we can do. We're constantly encountering aspects of human suffering that can't be fixed, that can't be made better. So what happens within this scenario when we encounter that kind of suffering? Well, it starts out the same. The patient is suffering, and you go in, you sit at the patient's bedside, and the patient surprises you, perhaps by saying, I feel like I'm going crazy, nothing is helping, I'm scared, I don't want to die, what have I done to deserve this? And then adds, if you can read it, promise me I'm not going to die, promise me. So somebody who looks you in the eye and asks you asks you for the impossible. So how do you react when somebody looks at you in the eye and asks you the impossible? That's what we're looking at here. Well, what we do is we do what we can to help. We do what we can to treat the physical symptoms. We do what we can to improve communication within the family system, to offer what emotional, psychological, spiritual support we can to the patient, to the family. But things don't get better. She is still looking you straight in the face and asking you for a kind of reassurance that you just don't have to give. So if we had a little more time for this, I'd probably almost take you through a guided visualization at this point, ask you to close your eyes, just to imagine how you feel when somebody does look at you in that way and ask you that kind of favor. So what tends to happen in this power relationship, in this non-self-aware context, is reactive behavior, where the clinician reacts either through fight, which takes the form of over-treatment, or flight, as in, I'm sorry, there's nothing else I can do to help. Hopefully, I have a colleague who I'll ask to come visit, resulting in a patient, perhaps, who does feel abandoned, or the clinician freezes from the neck down, all goes numb, and the patient on the other side of that feels isolated and confused. What's happening here? So Guggenbull Craig, referring on the limits of the power relationship, said the problem with the power relationship is over-identification by the clinician with the healer pole of the archetype. And that's archetypal psychology language, but basically the problem is that the inner healer is not awakened in the patient. That's perhaps the even bigger tragedy here. So I can't see what I've got up there, but I think if I remember correctly, it is there another possibility? Is there another way of doing this? And there is. And this is the wounded healer relationship. So the wounded healer relationship starts out exactly the same way. We're looking here at a clinician who has cultivated some of that background field of self-awareness and is bringing that with them where they go. So it starts out the same. And the clinician responds by doing what he can to help. When it's apparent that that's not helping, it's discussed within the team, and other members of the team come in perhaps with something different from a different angle, again offering what they can, but it still doesn't help. She's still looking you straight in the face and asking you to promise her that she's not going to die when it's apparent that she is going to die very, very soon. So what happens? Well, remember, we're dealing here with a clinician who has some self-awareness. And that means that at this moment, the clinician begins to recognize what's happening here. Because through self-knowledge and self-empathy and mindfulness and contemplative awareness, the sort of things Radhule discussed, the clinician has cultivated a capacity in the moment to notice what's happening internally, subjectively, and is able to press a sort of internal pause button. So this is all perhaps happening just seamlessly in the moment, but this is kind of slowing it down, kind of with one psychological frame after the next. We're pressing the pause button. And as the clinician presses the pause button, she or he notices, I recognize what's going on here. I recognize the buttons that are being pressed when I'm in a situation where I don't know what to do, where I'm in a situation of clinical impotence, where really there's nothing else I can do to make this situation better, that there are limits to my power as a clinician to intervene, to make this better. So what's coming into awareness in this brief internal dialogue is an awareness of limit, an awareness of, within the language of the wounded healer, of the wounds of the clinician, or the limits of the clinician. And so there's a sort of internal healing process happening here for the clinician at this moment. It may not feel good, but it actually is humanizing. The clinician, at least internally, is coming down off the pedestal and is noticing the contact between their feet and the ground, and there's a certain relief in that. But of course, they're still not able to give the patient what the patient is asking of them. And at this moment, we realize we're at a juncture where we have a choice. And again, we have a choice because we have this capacity of self-awareness. If we didn't have the self-awareness, it's kind of just reactivity without choice. But with self-awareness, we can choose where we go next. And it may be that we realize we're out of our depth, this is overwhelming, I really need a time out, and that's what we need to find a way, hopefully skillfully, and hopefully compassionately to communicate to the patient. We literally need to step back for a bit to regroup, to breathe before we can come forward again. Or it may be that we find a way of saying to our patient, I'm sorry, I cannot promise you what you're asking me. I cannot promise you that you're not going to die, but I can promise you that I'm going to stay involved in your care. I can promise you that I'm going to come back and see you later today. I can promise you that as a team that we're going to continue to do everything we can to help you and your family. So there's the naming of the limit, but there is also a reassurance of ongoing relationship and presence. And what we're doing when we're doing that is we're not only admitting to our the limits of what we have to offer, we're also energetically and psychologically, we're also handing back to the patient what they've wanted to hand over to us, which is the problem. We were actually, in a way, saying this suffering belongs to you. I can be present to you in your suffering. But I can't take this away. But this act of handing back, but in the presence of compassionate presence, encourages the patient to stay with their experience. And then something mysterious may happen. And in Rumi's words, your defects are the way that glory gets manifested. Whoever sees clearly what is diseased in himself begins to gallop on the way. Self-complacency blocks the workmanship. Don't turn your head. Keep looking at the bandaged place. That is where the light enters you. Or as Mark Nepo puts it in his poem, Accepting This, ultimately, we are small living things awakened in the stream, not gods who carve out rivers. So it's that move from that lonely, omnipotent fantasy of us as clinicians that can do everything to a much more human place. And this is describing the experience not only of the patient, but also of the clinician. Are you getting out your stick? Okay. He warned me that I was going to. I've always wondered what happens in these Zen sessions. You start dozing off. So I'm nearly finished. So at this point, the patient may turn to you and say, you know, the pain is still there, but I can live with it now. This isn't necessarily a happy ever after outcome, but there is a subtle and very important internal shift that the patient themselves begins to experience a greater inner spaciousness. And what is happening is that the patient is actually beginning to discover the reality of their inner healer. And being in the presence of somebody who is encountering their own inner healer is itself a healing experience. And you know, this has been referred to as a sort of paradoxical reciprocity. No longer is it just the clinician, handing it down from on high. The flow energetically is now on the ground. It's horizontal. Paradoxical reciprocity, it's also referred to as bidirectionality. That speaks to that sense of being enriched, even in a situation of great suffering. And I think this is what self-awareness-based empathic practice, our exquisite empathy, makes possible. And we're entering here the mystery of compassion. Thank you.